Between 2012 and 2023, we start focusing even more and more on scalability. And that scalability was on the workforce development in particular. In our original ABC model, the care navigator who delivered the evidence-based protocol and coordinated the care was nurse practitioner. When we moved it to the program, it was very hard to find nurse practitioners, at least in Indianapolis. So we split the nurse practitioner position into a social worker, master social worker, and a nurse who were kind of like a care navigator team. And then between 2012 and afterward, with support from CMS and the NI and Ashkenazi, we created this community health worker as the main care navigator, as a way of our scale, as a way to scale our intervention more. We evaluated it, it worked. We connected more with University of Nebraska and UCSF. We even founded a company called Preferred Population Health Management to scale this program even more or distribute this program across. And within 3 years or so, we served around 5,000 patients in Indiana between 2012 and 2015. Then we faced a big barrier of how can we sustain this program, because the current payment system were not sufficient enough to sustain the program and even create demand for it. And that's where we discovered, at least our group, this big difference between a need and a demand. And in Agile Science, always alert us that just because you have a need, that doesn't mean there's demand to fix that need. That these two words, need and demand, are very, very different constructs. And in order for you to meet a need, you need to have a demand for that need, and that demand defined by certain stakeholders are willing to allocate resources to solve and meet that demand. So when we faced that sustainability problem, at least 2015, 2016, we were able to diagnose the problem for sustainability is creation of demand. And that's where we had to create a village to work together to develop demand for the aging brain care model in particular, but more general, the collaborative dementia care model. And this is where we reached out to amazing people and advocates from the Alzheimer's Association, from AARP, Us Against Alzheimer's Disease, the John A. Hartford Foundation, the Milken Institute, and the NIA member in the summit. Together, we start trying to figure out how to create demand. Our group developed an alternative payment model to create demand for delivering the collaborative care model. We had the meetings and got input from Jürgen Unitzer, who developed a payment model for impact, and he gave us a lot of pros and cons of using fee-for-service versus an alternative payment model. We settled on an alternative payment model. And then with luck and an amazing work, we were able to team up with CMS, who in July of 2023 adopted or now announced the GUIDE program as an alternative payment model that will pay for delivering comprehensive dementia care services. And in 2024, it selected 400 organizations across the United States that have been approved by CMS to deliver the GUIDE model over the next 8 years. 100 of them start delivering the model in July of 2024, and 300 will start delivering the model this coming July of 2025. And us at Ashkenazi, where the birthplace of the collaborative dementia care model, we were one of the first 100 organization, and we started delivering the GUIDE last July. Then we didn't stop there. We started noticing the collaborative care model, the same way how collaborative care model was built on depression care model. We moved it to dementia. We noticed that we can actually use the collaborative care model as a delivery model for serving other vulnerable population with complex biopsychosocial need. for us in particular, the ICU survivors, surgical trauma survivors, delirium survivors, and we are working on that piece. We have published 2 clinical trial that show some benefits in the trauma survivor who have a pre-existing mental health problem. ICU survivor didn't work, most likely because of our dose and our fidelity was not there. And we are in the field right now testing collaborative care model for delirium survivors. We also scaled the ABC model to be delivered by community-based workforce, not just community health worker hired by the hospital system, but also um, a community health worker who can be hired by area on aging. And we call that our ABC community. We are using now technology, and we are in the field where we are developing or testing a mobile health technology that can deliver the collaborative care model with text-based and telephone-based communication with a coach 24/7. We have expanded the collaborative care model for other population focus on palliative care. And just last month or so, Dr. Sachs from our group published in JAMA the results of collaborative care model for dementia that focus on those who have moderate to severe dementia living in a community, and found that it actually was able to reduce emergency room visits. And then we are now focusing over the next 10 years, at least in Ashkenazi and IU Health, to expand our guide program. Specifically Ashkenazi, we are hopeful within the next 3 years to serve at least 1,800 patients per year. It's a very audacious goal, but we think we need to do that because there's a lot of unmet need in Indiana, and we hope that by expanding the guide model, we can serve as many of this need as possible. And I mentioned already the workforce evolution for our ABC program. The clinical trial, the care navigation was delivered primarily by a nurse practitioner. When in the first version of ABC program as a clinical program, we delivered it by a care navigation by an RN and a social work. Next version was by community health worker, and now we are trying to deliver it by mobile health technology and potential artificial intelligence. The tools that ABC program, beside the care navigations and the support, the interdisciplinary team that support the care navigator, we have the Healthy Aging Rate Care Monitor, self-report version, and caregiver report version, and I'll go over it a little bit. We have a care coordination software that connects the monitor results with a specific evidence-based protocol and take an input from the care giver and the patient to develop the first version of the care plan. We have a specific caregiver booklet and educational material for the caregiver. We have a list of a scale of anticholinergic cognitive burden that allow us to identify medication with adverse anticholinergic cognitive effect. We have replication manual for sustainability, and we have online training for dementia care coaches or navigators. So let me tell you about the HABC monitor. HABC monitor it's a one survey, one scale that capture the problem that the caregiver or the patient face when they deal with the cognitive, functional, behavioral, and psychological disability-related dementia and the caregiver own stress. And the way it does it, it's very similar to PHQ-9. It asks the caregiver, in this case, that over the past 2 weeks, how often did their loved one have a problem with? And we define the problem by stating the problem is considered a problem not just if the patient is not able to do it, but because the patient is not able to do something, or because the patient displaying certain symptom is stressing them out or stressing out the caregiver. If that happens, then that's considered a problem in that specific domain. So we said, over the past 2 weeks, did your loved one have a problem with this and caused him stress or you stress? And we have a list of cognitive problem, potential problem, or cognitive task that can lead to problem, set of functional tasks can lead to problem, and set of behavioral and psychological symptom that can lead to problem. And then we also ask specific issue related to the caregiver about the caregiver concern about financial health, physical health, mental health, and the future. And based on that number, each item can be 0, 1, 2, 3, and we add them. And based on the total number, we consider a patient is in the green zone if their number was below 15, yellow zone below between 15 and 24, orange zone between 25 and 35, and red above 35 or 36 and above.